Welcome to this panel discussion today on palliative and hospice care from a Catholic perspective. This is the second of two events that the Institute for Human Ecology has done with the National Catholic Bioethics Center. So let me tell you a little bit about these two institutions. The Institute for Human Ecology at the Catholic University of America in Washington, D.C. educates university students to, quote, give the Republic her best citizens, end quote, sponsors multidisciplinary academic research on the intersection of human flourishing and Catholic social doctrine, and organizes events encouraging conversation between the academy and the public square, like the ones we're doing today. The National Catholic Bioethics Center, which is located in Philadelphia, provides education, guidance, and resources to the church, to Catholics, to the bishops, and to society to uphold the dignity of the human person in healthcare and in biomedical ethics. Let me introduce the speakers today. First, my name is Bill Saunders. I am the director of the program in human rights at the Catholic, with the Institute for Human Ecology at the Catholic University of America. I have a Master of Arts program in human rights, and some of you listening might wonder, well, is bioethics part of human rights? And the answer is yes. One of our required courses in a human rights program is one in bioethics. Both those disciplines are concerned with the dignity of the human person and with the common good. Also, I am an affiliated scholar with the Pellegrino Center for Clinical Ethics at Georgetown Medical School, and I write a regular column for the National Catholic Bioethics Quarterly, which Joseph Meany's organization publishes, and I've been involved in bioethics for a long time, particularly since the stem cell and cloning debates around the year 2000. Let me introduce our other speakers. Joseph Meany is president of the National Catholic Bioethics Center. He received his PhD in bioethics from the Catholic University of the Sacred Heart in Rome. He was director of international outreach and expansion for Human Life International for many years, and is a leading expert on the international pro-life and pro-family movements. He's traveled around the world and spoken in many countries, and I've had the privilege of coming to interacting with him at a number of those events. He has also written many popular articles. He was the general editor of the English edition and co-author with his father, Dr. Michael Meany, of a chapter in the Pontifical Council for the Family's Lexicon, ambiguous and debatable terms regarding family life and ethical questions, and he's published in a number of scholarly journals. Dr. Carrie Ann Page is Chief Medical Officer for Hospice, Palliative Care, and Home Care Services, and Senior Vice President at Catholic Health, Long Island. Dr. Page has over 20 years of experience as a medical director and clinician with expertise in enhancing the care of people dealing with a serious and life-limiting illness. She's the medical director for Good Shepherd Hospice, which provides hospital-based and community-based palliative care services, as well as traditional home, hospice, and inpatient hospice services, serving over 550 patients each day. She also serves as medical director for Catholic Home Care, the health system's certified home health agency. After earning her medical degree from New York University School of Medicine, she completed a residency in internal medicine at Columbia University Medical Center and was chosen to serve as a chief resident. She is an assistant clinical professor of medicine at Columbia Medical School. So that's the speakers let me give you one or two words about the format and we'll get started. You can submit your questions to the Q&A box at the bottom of your screen. Our folks, our associates working with us will then get those questions to me and we'll have a discussion. We'll probably have Q&A around 2:30 or 2:40, but there's, get your questions in as soon as you can. When we did our first event, we weren't able to get to all the questions. I doubt we'll be able to today. So if you have a burning question you want to ask, get it in soon. So as we mentioned on the first panel we did a couple of weeks ago, the COVID pandemic, all the restrictions that have been imposed on all of us and all that we're living under, has caused a lot of people to think about mortality and medical issues of dying, of pain management, etc. So we want to look at that today. First, with Joseph Meany, with some reflections on the general situation, and then we want to talk to Dr. Page about how Catholic Health Long Island approaches these issues. So Joseph, I'll turn it over to you.
Wonderful. So thank you very much. Yes, it's a real pleasure to be with you and to work together with Catholic University of America. The National Catholic Bioethics Center is one of the oldest bioethics institutions in the world. We went back to 1972, and we were a project of the Catholic Hospital Association and the Conference of Catholic Bishops, which have since grown even further and changed names. We even changed names as well. We used to be the St. John the 23rd Center, but it's such an important topic. End-of-life care, palliative care, hospice care. And there's so many misunderstandings about what that really means. And one of the things that I think is least well understood is that what we're talking about from a Catholic perspective, when we're talking about, the Catholic view of how palliative care should be delivered, how hospice care should be delivered, and in fact, even, the standard view is that it must be multidisciplinary, that it's holistic, it's patient-centered. So we're looking about care that is not just about a disease and treating symptoms. Now, it's all about helping the whole patient. So obviously physical pain and treating physical pain is a key component, but it's not the sum total of palliative care and hospice care. And what we are also talking about, and from the Catholic perspective, the most important part is the spiritual part, the spiritual care of these patients, and the psychological and the social care, and taking in the whole family situation, not just the patient in isolation, and not just the disease in isolation, but the whole patient and the whole patient's situation. So, body, soul, mind, and spirit. And from the Catholic perspective, we have to always keep in mind the most important moment in our entire existence is the instant of death. So as Catholics, we believe that up until the very final moment when we die, we can either convert and turn towards God, or we can turn away. And the famous deathbed conversions of individuals who led horrible lives, and yet at the last moment were kind of snatched, by a conversion, is so incredibly beautiful. The opposite is also possible. A person could at the last moment sort of despair and reject God and turn away, etc. And one of the greatest tragedies that I see with regard to assisted suicide and euthanasia is that if the person is consciously doing this, their final act, their final moment really is to commit suicide, which is spiritually just ruinous, and you have to hope that they're not fully responsible. But the point is, we have to be very, very concerned about how people die. The Catholic tradition speaks about the ars moriendi, the art of dying. And, a traditional Catholic prayer is to pray for deliverance against an unexpected death. The worst situation for a Catholic is, if you're not in a state of grace, if you're in a bad spiritual place, and then you suddenly die without having a chance to convert, that is a real tragedy. That's a horrible situation, and people would pray for centuries to avoid that. And so when we're talking about good palliative care, good hospice care, we're talking about, from a Catholic perspective, one that is very, very spiritually oriented, bringing the sacraments, helping the person to reconcile with loved ones, helping the person, to be in a situation where they're not in a clinical depression, where they're not, despairing, but they, have hope, and they're, turned towards the future, because, physical life is not all we believe in. We believe in eternal life. And hospice care can be such an incredibly beautiful situation. And I'll just give an example from my own father. My father passed away in 2017. He was suffering from dementia at the end. He had a fall. It broke several ribs and had problems with his back. He was in the hospital, and we were told very quickly that there was not much that could be done, that he was kind of at the end of his life, and what did we want to do? And, in the hospital, the situation, we tried to transform the hospital room into a little mini chapel, right? I mean, he had a Our Lady of Guadalupe blanket on top of him, and he had EWTN on the television, and he had a statue of the Sacred Heart of Jesus in his room, and people were coming in to bring him the sacraments, and he received the sacrament of the sick, and we had people staying with him and praying with him. He even had a scapular hanging from one of his big toes. I mean, it was beautiful. It was a very beautiful sort of, Catholic culture in all its aspects. But the hospital, in its general, and this hospital in particular, was not a very peaceful place to be. There were people coming in at 2 and 3 in the morning to wake him up and do a test, and there were loud announcements overhead, and all kinds of noise and hustle and bustle, et cetera. It was not the most peaceful environment. So we enrolled my father in hospice care. We brought him home. He was in our living room, and of course we had round-the-clock care with him, where family members were sitting with him, and we had the pain management was there, and the nurses and other people, were bringing in what needed to be done medically. But the whole environment, if we talk about a good death, we're in the year of Saint Joseph, this year proclaimed by the church, and Saint Joseph is the patron of a good death. And why is that? Because he died with Mary and Jesus at his side, right? In a loving, peaceful environment that wasn't overly medicalized. But was just a very beautiful, spiritual and comfort situation. Well, we tried to imitate that with my father, with loved ones coming to say that they loved him, and were praying for him, and he would just express his love to everybody who came. It was so beautiful, because he was suffering from dementia. He couldn't really say much, but he just kept telling everybody he saw, Jesus loves you. You can't imagine how much Jesus loves you. And you tell this to the nurses and the doctors and everybody. It was wonderful. And that you really got a sense of, this is how a true believer dies. And that's, I would hope, the situation that many, many people could be in their final days and moments. Unfortunately, you have many, many other scenarios that play out, where individuals are either over-medicated to where, they're unconscious, and they're not able to reconcile and to make their final preparations, receive the sacraments, or there are situations where, their general care is not being taken care of, they may be dehydrated or other things like that. And what people need to realize is that good hospice care, good palliative care, and of course, basically hospice care is end-of-life care. It's palliative care at the end of life. Palliative care, doesn't have to be at the end of life. It could be at many stages. But the important thing is that we are giving the patient the best possible care they can receive, and not putting them in a situation that is overly medicalized, overly, distracting, if you will, from the essentials. And what are the essentials? Well, love. And the love of one's closest family members, one's closest friends, and the love of God. And being in a situation that is peaceful, that, everything is done for the comfort of the patient, everything is done to help the patient, but, oriented towards our final end. And unfortunately, because medical science has developed to such a high degree, there's much more that we can do medically than maybe what we should do. And at the NCBC, our most frequent consult is at the end of life, and people are asking questions, should we do this experimental treatment? Should we do this other thing, or should we, basically be trying to prepare for the end and rejecting what would be, extraordinary treatment, but, providing all the ordinary care that the patient needs. And it's a very important conversation because there are so many, all of us basically, are either going to come to that situation in our own lives or with a loved one. And it's something that needs to be thought about. So, at ncbcenter.org, if you go to our shop tab, you can see that we have our guide to palliative care and hospice and our end of life guide for making end of life decisions, most popular publications that we have, and such an important topic of conversation.
So, Carrie Ann, tell us about Catholic Health.
My pleasure. Good afternoon. It's an honor to be with everybody. Catholic Health is an integrated health system located on Long Island, New York, in the suburbs of New York City, where we serve a population of about 3 million people. The health system consists of 6 hospitals, 3 nursing homes, a large home health agency, and a fairly large hospice organization, which I am privileged to serve as the chief medical officer for, named Good Shepherd Hospice. Within our hospice organization, we provide both palliative care and hospice services. And we are fortunate to be able to provide those resources across all of the venues of the health system, and at all stages of serious illness. So we operate in-hospital consultation services, so patients who are admitted to the hospital with various medical problems who need specialty palliative care services. We have a home-based service for patients who are physically and functionally homebound, who can't necessarily get out to an office setting. We do have an office-based practice. And then we have our large hospice service, which serves over 450 patients every day, the vast majority of whom are at home, being cared for by the hospice in partnership with their families and other caregivers to provide symptom control and the best possible experience when their life expectancy is limited. I wanted to share a slide with our group today that helps us understand how our usual forms of medical care integrate with palliative care and hospice. And I find this graphic to be very helpful in terms of allowing us to really understand how we should think about the appropriateness and the place that hospice and palliative care has in the general medical system. Can everybody see that? Great. So in this graph on the left-hand side, you see that we have the diagnosis of a serious illness. So when we use the term serious illness, we're generally talking about a progressive disease for which there is often no cure that will limit life expectancy. The common illnesses we're talking about here are advanced cancers, things like congestive heart failure, chronic obstructive pulmonary disease, dementia, ALS, Parkinson's disease, and other diseases that over time will progress. So these illnesses can be present in a patient's life for sometimes a few months, but more often many years. And it's important that we think about the role that palliative care has from the very beginning of that illness, right? So we define palliative care broadly as therapies that relieve suffering and improve the quality of life and address the holistic elements of the illness in the patient's life and their family's life as well. So as Joseph pointed out, we're talking not only about the management of physical symptoms, but addressing emotional and psychosocial stresses and symptoms and spiritual concerns about the illness and how the illness impacts the individual's spiritual life and how their spiritual life supports their experience of the illness. At the onset of the illness, at the time of diagnosis, most of our attention in the medical realm is aimed at therapies that modify the disease. Sometimes our goal is cure. When cure is not possible, often our goal is to extend life for as long as possible. But there's always a component of palliative care involved in that. And that may be delivered by the patient's primary doctor, by the specialist that's treating them. When we talk about palliative care in this setting, we're using a broad definition to encompass the kind of care that we hope our medical providers provide, aimed at alleviating suffering, treating symptoms, and allowing people to live and function as best as possible in the constraints of the disease. As the disease progresses, we see a couple things happen. The therapies that modify the disease may become less effective. Oh, I just lost my screen. Can you all see it? There we go. We're back? Good, okay. The therapies that modify disease may become less effective, or they may become more and more burdensome for the individual, and the individual may decide not to pursue them. As those therapies become less prominent in our overall care, more of our attention and focus switches to therapies aimed at relieving suffering and improving the quality of life. And so we see that the proportion of palliative interventions grows across the treatment course of the disease. Now you notice that that's not a straight line between so-called modifying therapies and symptom-driven therapies. And that's because the course of illness is not always straightforward. And there are going to be times when there are more palliative interventions that are necessary for a patient and family, and relatively less at various stages of the disease. As we approach more and more advancement in late stage in the disease, we get to a point where we discover that really all of our therapy is palliative in nature. It's all aimed at relieving suffering and controlling symptoms and helping people live as fully as possible as their life expectancy shortens. And this is conceptually the time at which we think the transition to hospice care is appropriate, because hospice care is defined as just that. Symptom control and therapies aimed at preserving quality of life and relieving suffering, typically without the continuation of therapies that are designed to attempt to cure the disease or prolong life. So hospice care is designed to keep people comfortable, to keep their symptoms under control, and to help them live as fully as possible when their life expectancy is limited. In the United States, Medicare defines that point in time as being approximately 6 months before the anticipated death of the patient. And that is one of the eligibility criteria for hospice enrollment in Medicare. Another key component to hospice care is that hospice is not about the patient alone. In hospice care, the patient and their family are the focus of our care. So not only how the disease affects the patient is the concern of the hospice interdisciplinary team, but how their family members cope with the illness, how their family members are affected by the illness are incredibly important as well. And care continues for family and other caregivers after the physical death of the patient through the provision of bereavement care for up to 13 months after the patient themselves passes away. So again, hospice is a very holistic approach that encompasses physical care, spiritual care, emotional care, and psychosocial care delivered to patients and families throughout the course of the final phase of life. The goal is neither to extend life nor to prolong death, but to help people maintain the best quality of life possible during this time. So with that, I'll turn it back to Bill.
Thank you. let me just, are there, I wondered if either of you would give general guidance for people who have elderly parents or sick parents, or, you know, other loved ones who you can kind of see a long-term trajectory of a few years of, you know, decline and then death, and how they should prepare for that. How should they, what should they begin doing now? They don't have a loved one that's in extremis, but what should they be doing now to prepare for the end? Carrie Ann or Joseph, who wants to go first? Either one.
I might jump in first.
Okay.
Simply, I think it's so important to have these conversations, because our society, sadly, is very much in denial about death. And it's not a polite topic of conversation, you know, that a loved one is dying or, you know, is very fragile and probably will not survive very much longer in terms of years. That's a very difficult conversation to have. And it's such an important conversation to have. It makes such a difference to that person's almost sense of well-being, right? People know that they don't have much time left, and if they can't talk about it, that's a huge burden. And sometimes I think, you know, in the medical community as well, there's kind of a sense of like, we're going to fight this, you know, et cetera. And that's fine, and it's good, and we definitely should be trying, you know, and praying for miracles, et cetera. But we should also be looking at what this person really needs at the end of their life, and what, you know, decisions need to be made, including, you know, having a medical proxy, right? Someone who can make decisions, because one of the most horrible situations that can happen to a family is you have a loved one, you know, who's unconscious in the hospital. There's some doubt as to what should be done, and then the family is fighting among themselves as to what should be done. And there's no clear person who has the authority to make a decision there. And it can create just a toxic situation for the healthcare institution, but also for the families within themselves. So having talked about, you know, what they would like at the end of life, you know, what kind of plan they have, that's so beautiful. And to have all the spiritual care, right? To see this as an amazing opportunity to grow closer to God and to reconcile and to finish our lives well. That's amazing.
I couldn't agree more. It is so incredibly important that patients and their loved ones talk about what it is that the patient wants and what the patient's goals and values are for living with a serious illness, particularly at the end of life. That includes appointing a healthcare agent, as Joe mentioned, right? A person who can make decisions for you when you're not able to make decisions for yourself. It includes practical planning about what's going to happen if you need more physical help, what's going to happen if you live alone and you're not able to maintain, you know, your own existence safely in that setting any longer, right? Making provisions for those circumstances are incredibly important, and they keep the patient in control. So many people kind of, you know, we see oftentimes people who are fiercely independent and they want to maintain control of how they're going to live their life and what things are going to look like. And yet when they're faced with these challenges, they're kind of paralyzed about how to deal with them. When in reality, when people make those decisions and plan for those circumstances ahead of time, they are retaining control, because that plan allows for their wishes and their values to really be brought to fruition at the time when they're necessary, right? Indicating what your goals are. For many people, you know, they tell us they'd rather be home than be in a hospital or perhaps be in a nursing home. We can make that happen, and people can make that happen for themselves by planning for those kinds of eventualities. This is a lot of work that palliative care professionals do early on in the course of illness in helping patients and families plan for what comes next or what the future will look like. Sometimes you hear the term advanced care planning used. That refers not only to medical decision making, but also to some of that practical planning as well.
Okay, so let me ask you a question from the audience. What, in your views, is the best distinguishing mark of Catholic hospice care or palliative care versus secular hospice or palliative care?
Yeah.
Carrie Ann, I remember, I believe, when we had a discussion before, that there are a lot of laws in New York that set certain standards to which all hospice must conform. But perhaps you could comment first on that, distinguishing marks of Catholic hospice care or palliative care versus secular.
Sure. All hospice care, regardless of the faith basis or the secular basis of the provider, is under Medicare regulation compelled to provide multidisciplinary, holistic care that includes, emotional and social support, as well as spiritual support. And the unique thing about hospice in the healthcare system is that it's really the only place that that spiritual care is mandated and actually paid for by the government as part of the overall benefit. That being said, providers put different levels of emphasis on the kind of care they provide in these realms. And I think that one of the things that differentiates Catholic providers and other faith-based providers as well is their commitment to mission, their provision and recognition of the importance of spiritual services as a primary hallmark of the care they give, as well as the commitment to provide care to the most vulnerable and underserved in our populations. So caring for populations that might otherwise not be well recognized, the homeless, the incarcerated, the people who have no insurance, the undocumented, etc. Catholic hospices really see as a fundamental part of their mission these populations who are most vulnerable among us as amongst the most the group who needs our help the most.
Joseph.
Yeah, I would just add that it's so important to look at the hospice provider. In different parts of the country, the situation is very different. But where I grew up in Texas, there are dozens and dozens of different hospices out there, and they are not equal. Some of them do an amazing job, and some of them do a really bad job. So you need to do your research a bit. There are other parts of the country where there's, like in New York, Carrie Ann was saying, there's a kind of a little bit more quality control that goes on in terms of how many, hospice providers are actually out there, and it's easier to evaluate them, and they're pretty similar in what they offer. But it's so important to, have questions to the hospice providers, say, what kind of services do you provide and what kind do you not? To find out somebody who's been through that hospice program, their family has been through it, to see what their experience was. It's again, I just have to repeat, the moment of death is so incredibly important. We want really the best for our loved ones, and that means also choosing a very good hospice program.
Joseph, I put in a plug for, I think the National Catholic Bioethics Center has a publication on on palliative and hospice care, and has a series of questions at the back of it.
Right.
You might want to mention that. I've forgotten the name of it, but I remember that there were a lot of good questions that would help somebody to begin to do this evaluation you're talking about.
Right, because one of the things that a good hospice will provide is not just physical pain management, but also, maintaining any therapy that actually helps with symptom management. So will they give the patient antibiotics? Will they make sure that the patient is hydrated? Will they make sure that they're properly fed? Will they accept a person on dialysis or not? All these different questions are very important to a hospice provider, because it'll sort of tell you what their attitude is, right? A good Catholic hospice is looking at helping the entire person, and not just their physical suffering. And in a sense, the other thing that the church has been very strong about is that we don't want to keep people unconscious. If a person is unconscious all the way to death, really their last conscious moment is that moment they kind of determine their eternal destiny, right? We like people to be conscious as much as possible. And, you know, there's room for palliative sedation, but they can also be abused, right? Where an individual is basically over-medicated, and at which point they, you know, are not present to their loved ones for the end of their lives when it's so important. So it is important to see what the philosophy is and how much caring there is. You know, a good Catholic hospice will provide people with, you know, they'll treat the patient as Christ would treat that patient, you know, to have an incredible respect for their dignity and their love, you know, seeing this as a ministry of the church, really, as opposed to just simply a job. And that's the kind of hospice care that one would like to see.
Agreed. Agreed. Yeah, I just want to make a few other comments from the medical perspective around some of the things Joe's alluded to. I think it's important for a hospice to provide treatments that are aimed at symptom control and that are effective at providing symptoms.
Right.
And so sometimes we see patients or families come to us and say, well, I want X or I want Y, and I must have it. And a treatment that may have provided symptom control at an earlier phase of the illness may no longer be appropriate or may not provide the same level of symptom control in the final phase of life. And so it's important when you have that discussion with a hospice provider is to understand why something might or might not be offered. For example, hydration is a common example here. So for the patient who is awake and alert and perhaps not able to meet their caloric needs or meet their volume needs, hydration is very important to controlling symptoms and to allowing them to live as fully as possible. But when a patient has entered the actively dying phase and is naturally now no longer conscious, that same hydration may complicate matters and increase their secretions, increase their sense of breathlessness. And it often is appropriate that those interventions are stopped when it's clear they're no longer beneficial. And so the approach we take is not so much that a given intervention, you know, must always be offered or not always be offered, but how does that intervention fit our ultimate goals, which is to help the patient live as fully and as comfortably as possible for as long as is naturally possible.
And I would say that's part of an answer to the previous question too about, you know, when you're choosing a hospice or palliative care, you want doctors who listen to you as the family member, but you want doctors who approach it like Carrie Ann said, a doctor and a Catholic doctor who understands what a human being is, and as well as the scientific and medical aspects of one kind of treatment or another. So I think a distinctive the Catholic palliative and healthcare hospice care can offer is that you have people who should be sensitive to and trained in the Catholic perspective, at least on the human person. Now, I did get this question, Carrie Ann, that's directed primarily to you, but it says, what advice do you give doctors and students to provide holistic care when a patient has terminal illness? I think it's no secret that our healthcare system and our doctors sometimes struggle to see the person as a psychosomatic and spiritual whole.
The pressures on healthcare providers and on the healthcare system for various reasons can indeed interfere with our ability to treat people as dignified individuals, body, mind, spirit, and soul. But I would tell you that no one pursues a career in medicine without those aims. There are other opportunities in life that one could pursue if their goals were different. And so the vast majority of physicians really want to do that kind of job. they're not always necessarily able to focus on it at the particular moment, or they may not have the right kind of training. And that is really, I think, some of the shortfall we see, particularly in the palliative care and hospice realm, in helping to care for people with serious illness. This is not easy work. It may not feel comfortable for many people, but it is a skill, and it is something that requires training. And so I would encourage particularly young physicians and young physicians in training to pursue, education and training in basic palliative care skills. And we see more and more of this, thankfully, in our medical schools and our training programs across the country. And that's really important. I train students and residents and fellows at all levels, and I remind them that regardless of what field of medicine they go into, they're going to take care of people who are seriously ill, and they're going to take care of people who are going to die. And so they need to have the basic skills to be able to address people's goals, people's needs, people's desires, with regard to their care in the setting of a serious illness. And they need to have the skills to manage pain and manage anxiety and recognize depression and recognize suffering. But there are also specialists who work, predominantly in this area, like myself. And so it's never the sole responsibility of any one doctor to manage all of this. That's why in hospice and palliative medicine, we operate as an interdisciplinary team. It's not just the doctor, it's the nurse, it's the social worker, it's the chaplain, it's the volunteer, it's the aide, it's the therapist. It takes all of us with our specific areas of expertise to bring all of that to bear in a comprehensive way that supports the patient and family. And so building that kind of multidisciplinary work and asking for help when you need it are some of the most important aspects of managing patients for providers in what can be a very challenging situation.
Joseph, did you want to comment?
Oh, no, I definitely agree. Yeah, that this is important. And I would also, the earlier point, add as well. I mean, one of the most difficult ethical decisions, right, is at what point do certain therapies have to be discontinued because they've become extraordinary and they're so burdensome that the benefits are not really there. And if the person is not able to assimilate food and water at the end, then it could be a high burden without a real benefit. Now, no one wants to see a patient, and the church would be very opposed to a patient dying of dehydration, obviously, or malnutrition. But there's a happy middle there, where you're trying to provide the patient with as peaceful and as natural of a death as possible, where your emphasis is not on over medicalizing the situation, but still meeting all the ordinary needs and relieving them from any unnecessary suffering that they could have. So it's terrible to see how assisted suicide has kind of skewed the picture, because in some circumstances, groups that promote assisted suicide said, well, we're part of palliative care because we're providing, end of life, the final end of life choice, et cetera. And they want to kind of like insert themselves in a place where they do not belong because they're killing people, and palliative care and hospice, when it's done well, is allowing a person to die naturally, peacefully and in a very beautiful environment. And the two could not be more opposed, ideologically and philosophically.
Yeah, I just want to ask Carrie Ann one little piece there, something you said. You said that it's a team approach and all kinds of different people are involved. And you mentioned volunteers. I wonder if you say a word about volunteers and the role they can have in this.
Certainly. So hospice, again, is unique in with regard to other entities in the healthcare continuum, in that hospice has a requirement to provide volunteer services. So that grows out of the fact that in the United States, hospice was really a grassroots movement of patients and families and some providers who said, we want to seek a different way to provide care and comfort at the end of life aside from pursuing treatments that are not likely to be beneficial and cause lots of symptoms. And so when the government created the Medicare hospice benefit, it actually said, we appreciate the volunteer component of this movement, and we want to preserve it. And so hospices are required to provide 5% of their patient care hours in the form of volunteer services. So every hospice needs volunteers. And volunteers provide a host of services, from providing friendly visits to patients, social visits, play cards, read, provide companionship. In some circumstances, volunteers may provide vigil at the end of life, particularly if family can't be physically present. That's a great comfort they often can offer to families if they're far away, geographically distant, and have a loved one who's dying, and they fear that that person will die alone. Knowing that there is a concerned and compassionate person who accompanies that patient on their journey is a great service and a great gift. We have volunteers who provide practical help, run errands for patients and families, and who provide us with administrative and programmatic help, as well as support our bereavement programs and children's camps and the like. And so volunteers are very, very important. And I think, you know, as a Catholic organization and as a Catholic people, our mission to provide and support palliative and hospice care as being consistent with our faith gives us a great opportunity to put that mission into action in providing volunteer services in the hospice setting. And so, you know, I would encourage everyone to support the work of hospices, you know, in their community, however they can, through their prayers, through their volunteerism, through their financial resources, if that's appropriate for to support services that might not otherwise be covered by insurance reimbursement streams. There's lots of ways to help, and I think that that's an important mission perspective for all of us.
I think you would also say to people that one way to lessen an understandable fear of what happens at the end of life for their loved ones is their own involvement as volunteers in hospice care, right? They can learn more about it and feel more at home with it.
That's absolutely true. And, you know, it also is a gift that many of our families who have experienced hospice care give back, right? So they realize the benefits that they received when their family received hospice services, and in their effort to help other people have that same experience, will often, after an appropriate period of bereavement, come back to us and say, I want to volunteer so that some other family can have the support and the experience that our family had when we were in this situation.
Joseph, any comments on that?
Just one thing that hasn't been raised yet, and I was so impressed with at Catholic Health, was their in-hospital hospice program. Because a lot of people think of hospice only, you know, taking the patient home, but sometimes the patient's situation is so complicated from a medical perspective that it's not really possible to take them out of the hospital, but yet you can still provide a hospice-like environment. And it was such a beautiful way to see how they had transformed the hospital to look like a home. If you could comment on that, Carrie, it'd be great.
Sure. So we are very fortunate. We operate 2 dedicated inpatient hospice units. And as you mentioned, inpatient hospice care is designed for patients who medically can't be managed in the home setting. So their physical medical needs really require the technology and the expertise of round-the-clock nursing at the bedside, and the physical and equipment-related issues that we find in a hospital. But as you described in your own situation, Joe, the hospital is not built for caring for people at the end of life, right? Our hospitals are built to take us in when we're sick and to make us better and to send us home, right? And so an inpatient hospice environment needs to be different than the hospital environment to meet the needs of the patient and to meet the needs of their family at this very vulnerable and very sensitive time. And so an inpatient environment marries the best of the hospital technology and care with the best of the home and family environment. And so our units are designed to look like home and to feel like home as much as possible. And our care processes are designed to honor the individual patient and family's needs and values as much as possible. So we're not waking people up at 6 o'clock in the morning to do vital signs because that's when we decide we're going to do them. And we're not feeding everyone the same thing. And you know, we have flexibilities as best we can for extended visitation and the ability of family to stay. Now, COVID has changed a lot of that. Thankfully, we're able to now, with more and more people being vaccinated and infection rates dropping, be able to get back to liberalizing that kind of care. I'm very proud to say that throughout the pandemic, even when in our communities, hospitals were required to limit visitation completely, restrict it completely, our hospice was always able to provide visitation for our patients in our inpatient setting. It got curtailed, but we were always able to provide it. And so patients who spent their final hours and days with us had the ability to be accompanied by their family members in that setting. And that's a very important element to the care we provide.
I have another question that is related to this, is how would you recommend Catholic clergy and religious be involved in Catholic palliative care?
Yeah, so I mean, I have a sister who's a religious sister and who works a lot with the dying. And it's very beautiful, right, to have that ministry, particularly in cases where it's very distressing. You know, she works a lot with hospitals with, you know, very sick children, for instance, you know, and the parents need particular care. You know, it's so heartbreaking when you have a young child dying of leukemia, for instance, but you know, in any circumstance, family members need comfort and care, and it's really an opportunity. It's an incredible opportunity for the church. I mean, you know, a lot of us pass through life, you know, on a very superficial level, and we're not really thinking about the most important things, eternal life, in our relationship with God. But the approach of death, you know, sharpens the mind, sharpens our concentration, and can. And so it is such a moment for, you know, the clergy and for chaplains in general and spiritual care persons to come in and really provide a moment of grace, a moment for, you know, families to really think about what's important. And to sometimes, you know, all of our families, we've had conflicts or problems or other things, and we can put that aside because, you know, we are facing this incredibly serious, incredibly important moment for our loved one, and we want to get that right. And so I think particularly, you know, the biggest tragedy that I saw in terms of spiritual care during COVID was the number of hospitals that would not allow pastors, you know, would not allow priests in to provide the last rites. And, you know, as Catholics, there's hardly anything that is more important, you know, than the person receive the last rites before they die. Now, fortunately, this was not happening in Catholic hospitals because they would have, you know, chaplains that are on staff, but a lot of these secular hospitals that would allow priests in normally suddenly said, you're a visitor like everybody else and you're not allowed in. We had to object to that tremendously, you know, and many different bishops across the country really worked hard to ensure access because it's a right, a human right to receive the sacraments as a faithful person. And hospice should be, you know, an incredible environment for that, you know, which is not overly medicalized, overly, you know, busy, et cetera, but peaceful and supportive can really help, you know, not just the patient, but in the entire family to come to God.
I would add from a practical standpoint that that Catholic clergy and Catholic chaplains should get to know the palliative care and hospice providers in their community and make it known that their services are available, that they want to help, and they want to provide support not only to their parishioners, but to others of the faith who might need the care and attention of a Catholic priest, particularly at the end of life. You know, sometimes it can be a scramble if you are not in a Catholic organization and you have a patient who, you know, has no prior religious affiliation, but wants to see a priest. And I can tell you, having worked in some secular hospices, that it's not always that easy to make that happen. And so, you know, I would encourage, you know, our Catholic clergy to make themselves available and to, you know, provide their services in any way possible.
Here's a more specific or more pointed question. How would you respond to most requirements that some hospitals are placing on families in order to qualify? Some families have been told they will not qualify if they don't comply with these requirements from hospices. Is most post an issue with hospice care, Long Island area?
No, it's not, and we certainly don't require the completion. In New York State, it's called the MOLST. We certainly don't require its completion, and frankly, I don't know of any hospice provider that requires it. I will comment, and I know that there are a lot of ethical concerns around the use of the POLST or the MOLST, but in the patient population about which we're talking today, people at the end of life, these forms of advanced care planning and orders are often very appropriate. And we actually encourage their use for a very specific purpose. In the state of New York, where MOLST is the out of hospital orders around life-sustaining treatment, completion of the MOLST form is the only way to ensure that a patient has a do not intubate order in the community. So we find ourselves using that particular section when that is in concert with the patient's wishes. One of the things I think that many people may not understand about a POLST or a MOLST form is that while it has orders on it that refer to a lot of different types of treatment, antibiotics, hydration, resuscitation, etc., there's no requirement to complete them all. So some agencies will use a MOLST or a POLST form specifically for the resuscitation directives, much in the way they would use a do not resuscitate order form. And so I think you want to drill down and look, you know, and ask about the details of why a provider might be offering you the opportunity to complete a MOLST, and know that you have the ability to say, no, that's not what I wish to do. And if there's another legal form of an advanced directive around resuscitation or other treatments in your state, to ask for it.
And I would just add that at the Ncbc for a long time now, as we've reflected on these issues of end-of-life issues and advanced directives, we're more and more convinced that the best ethical and medical decision-making happens in the moment. You know, when you can see what the circumstances are for the patient, what the patient's wishes are. And it can be very problematic if a patient, you know, fills out a form when they're not sick, you know, 20 to 30 years ahead of time. And then when it actually happens, you know, later on, their views may have changed, medical technology may have changed. All these circumstances can be, you know, very different. And so having a medical proxy or a medical power of attorney, a person who's appointed, who you trust, you know, who has the same values, with whom you've discussed this, is a much safer way to make your wishes known than simply filling out a form, which can also be very limiting, right? I mean, one of the problems we see with it as well is that, you know, you can never know all the possible future scenarios. It's just impossible. And at the same time, you can, you know, in some sense, you know, not even know what is being offered to you. Well, would I want this or not? Maybe today I don't, and in the future I might want it, or vice versa. So it's, it can be useful. It certainly can, and particularly useful as you're getting closer and closer to the situation. But when you're trying to make decisions very far in the future, that's where it gets a little bit dicey.
Yeah.
There's a quote. So go ahead, Carrie.
I was just going to add that the key component to any of this kind of decision making is a thorough discussion about what the circumstances are, what the likelihood of the effectiveness of the proposed treatments or interventions are, and what the patient's values are about the kind of care they wish to receive. And, as Joe points out, a piece of paper in and of itself cannot accomplish that. And so part and parcel of signing any of those types of orders or directives is really having the conversation with your physician or nurse practitioner or other care provider about what your intentions are, and what the specifics about those treatments, may or may not offer you.
There's a question here about palliative care for families whose loved one has died.
Mm-hmm.
I'm interested both in how does a hospice view that? Is there some way that hospice is working with the families for what's going to happen when the loved one passes? But it also puts me in mind of that previous question about what clergy and religious can do, because one thing we know is the family's going to need spiritual care, and of course, hopefully they're in a parish and they're getting some spiritual care from the pastor, but there must be many people who've thought this through. So Carrie Ann, I ask you first, and then Joseph, their thoughts.
Sure. So as I pointed out on the slide, an integral part of hospice care is indeed bereavement care for the family that continues after the patient dies. But bereavement care doesn't start when the patient dies. It starts when the patient's admitted to hospice. And a bereavement risk assessment is performed at the time of admission, not only for the individuals in the family, but for the patient as well. We often find in the final phase of life, there's a lot of anticipatory grief that may exist for the patient as well as family members. So grieving doesn't necessarily start after the patient's died. It often starts long before. And having a loved one who's entering the final phase of life can bring up unresolved grief issues from the losses of other people earlier on, in both the experience of the patient and the experience of other family members. So bereavement counseling and spiritual counseling and other psychosocial supports are offered throughout the course of the care of the patient and family on the hospice program. And then again, after the patient's death, in a more formalized bereavement setting, a risk assessment is again done at the time of the patient's death. And then all families are offered opportunities for support, including individual counseling, group counseling. We run various workshops. And for more complicated situations where an individual might have complicated grief, or where their grief interacts with other mental health concerns, we can make other professional referrals and resources as well. I'll also mention that many hospices, including ours, also provide bereavement services to the community at large, so that you need not have had a loved one on the program in order to access our bereavement services. And we offer a whole host of programs for the general community, for schools, particularly if there's been a student or a teacher who's died. We have bereavement support in that setting. We've provided generalized bereavement support in our nursing homes and in our hospitals, particularly in light of the COVID pandemic, where many of our staff who are used to taking care of patients but not used to seeing so many people die have really been dramatically affected by that. And so many hospices provide those services as well, and they're really important. And so that's another way that we as a community can support the work of our hospice providers.
And I would just add, I was very, very moved with a family that lived just next door to where we were, who lost an adult son who was very young. He was recently married. His wife was pregnant. It was just a tremendous tragedy. It was a sporting accident. And at the time of the funeral, some of that deceased person's siblings were in real, anger and frustration. And you could just sense it at the funeral, that they were not at peace and they needed help. Bereavement help, et cetera. And our parish priest worked with that family, afterwards over time, and really was a constant presence with them, inviting them to engage with the faith community, to go on pilgrimages, et cetera. And then, just about a year afterwards, the younger son, who was the most affected, he had actually been next to his brother who had died out. It was an accident out on the ocean. He met a young Catholic lady and married, and it was just so beautiful to see how he went through this entire spiritual journey, but he needed help. Clearly, at the time of the funeral, he was at real risk of just turning against God, and despairing, because it was such a strong sense of rejection. How could this have happened? And when the church was there at his side and at his family's side, it just helped him over time to come to peace and also to go closer to God. So very beautiful to see what can happen.
Here's a question. My grandmother is somewhat reluctant to admit she's aging. How would you recommend that Catholic hospice care providers show kindness and charity to those elderly persons who struggle to accept the inevitable death, approaching death? They're not now sick, but they're very, they're elderly, and death is not as closer than it was when they were younger. What are some concrete practices that the family and healthcare providers can do to help the elderly prepare for death when they kind of naturally don't wish to age and die? Sure,
and it's death is not natural, right? It's something that is causes fear, and I think it's very important for family members to be aware of that, but also to do a little bit of research, to accompany that person. And I think the word accompaniment is so important, right? To be there. One of the terrible things that leads to assisted suicide, that leads to despair, is when people are abandoned. They feel alone. They feel like no one is coming to visit them, no one is taking care of them, and that is what needs to be fought in particular, right? We need to be showing love and compassion and care, and to raise the issues as it gets closer. Now, it may not be appropriate at some point, right? The individual may have years and years ahead of time, and they may not want to discuss it. My own father really did not want to discuss death at all, and so we had a very hard time arranging that as it was getting closer and closer, and then he was suffering from dementia, so it was difficult to discuss it with him. But as a family, then we discussed it among ourselves. What are we going to do, and how can we help? And be there for this loved one. It's very important to do that, and if the person is willing to participate, that is amazing. Such a wonderful thing. And to just, palliative care and hospice providers are open to this. Their chief complaint, in effect, is that people come to them too late. So it's not like you're going to get a rejection, and the palliative care or hospice providers can say, go away, come back later. No, they'll talk to you now. It's a good thing.
Yeah, and I think that, what we're really talking about here is in the realm of palliative care. And, as a practicing physician who has cared for lots of older individuals, I think it's important that we promote their independence as much as is possible and as much as they are interested in. Many people, as they age, worry about being burdens to their loved ones, or being cast aside, or somehow being marginalized. And that is sometimes why they, look to do it all and shoulder it all themselves. And the balance between helping them make decisions while maintaining their independence, I think is fundamental to all of us, really regardless of what age we are, right? We all want to have some say in how our life will unfold, right? And how things will move forward in the future. And so that model of shared decision-making, you know, we often talk about that in medicine, the concepts of shared decision-making, I think are really foundational here. And that when we approach the idea about decision-making in the face of serious illness or at the end of life, with the intention that we hope that our goal is to honor the patient's wishes and to promote their ability to be as independent and as present as possible, that is really how we have you know, our best success.
I think we're getting near the end of the panel, but our time. But I wanted to ask Joseph and then Carrie Ann if they had any final things they'd like to say about this topic. I think we'll be wrapping up in a couple of minutes.
Yeah, so I mean, as I was mentioning, we have this beautiful year of Saint Joseph, yeah, who's the patron saint of the sick and dying. But we also have a very recent document from the Congregation for the Doctrine of the Faith, the Samaritanus Bonus, the Good Samaritan, that talks about end-of-life issues. And very well done, very succinct, not very long. I really recommend that people go and read that, Samaritanus Bonus, the Latin for Good Samaritan, which you can find on the Vatican website. But it's very important as our society gets older. You know, the demography of most rich countries, you know, is an aging society, one that is facing a lot of these issues more and more, where there's a pressure pushing towards, you know, assisted suicide and other things. You know, we can just see the legislation happening, et cetera. To get end of life well, to do it well is so important, you know, and the church is really pushing us in this direction of, you know, accompanying our loved ones, of doing everything we can to spiritually prepare them and medically prepare them, and keeping in mind, you know, that everything that can be done doesn't mean that it should be done. You know, medical science has progressed to such an advanced level today that there are many possible interventions that are frankly too burdensome in almost all circumstances. So one has to make these choices. They're sometimes difficult, but not to put it off to the last moment, you know, to be really spiritually attuned to the fact that one has to think about memento mori, right? Remember that you will die, but also that one wants to help individuals, you know, to have a very beautiful, peaceful, natural end, and not to leave that off to the last moment when, you know, there's all kinds of other things that intervene, and emotions and other things that can make it very difficult.
Yeah. And I would reiterate that, you know, we see clearly that palliative care services are underutilized in our healthcare systems, and hospice services are utilized way too late in the course of the end of life. You know, in the United States, where the hospice benefit is intended for the last 6 months of life, the median length of stay on hospice, the 50% mark, is about 2 weeks, 2.5 weeks. Right? It's a very, very short period of time. Nearly a third of people are on a hospice program for less than a week. So we have not provided our fellow citizens and their families with the kind of care they deserve and can benefit from at the end of life. And so we need to endeavor to embrace hospice care earlier on in the trajectory of end of life care. You know, Cicely Saunders, who was the founder of modern hospice medicine, an English woman who was a social worker, a nurse, and a physician, you know, is known for a kind of famous quote, which is really the promise of hospice. And she said, you know, we will do all we can, not only to help you die peacefully, but to help you live until you die. And that is really the promise of hospice care. And the promise of our Catholic faith, which is to accompany people and to relieve their suffering and to help them live as fully as they can for as long as they're able.
And I would just say that the extent that we do those things, the pressure for assisted suicide is greatly reduced. I've been involved in that issue myself, and as Joseph mentioned, it's the fear of being alone.
Mhm.
The more you can accompany somebody through the end, the less that they even think about such things. And also sometimes they're clinically depressed. So you treat that depression, you accompany them, you palliate their pain, which we have great resources to do, and people can die peaceful, contented death. So as Joseph said, assisted suicide is I mean, I don't know how, I don't want to put it too colorfully, but it's the worst choice. It's an unbelievable choice, and it makes no sense because, we had people ask, what can religious and clergy do? Well, one thing is, again, you can identify people. The hospice can help you identify people. They need accompaniment. We as Catholics can volunteer at hospices to accompany people. We can, pick the right kind of hospices. We can start early. We can not hide from the fact that we're all going to die. But, as Catholics, we know that death is the doorway to eternal life. So although it's natural to fear it, the supernatural end is going to be beautiful. So I just hope that those listening today have seen insights into these issues of suffering, palliation, and death and hospice care from our panelists. And I thank the panelists. I thank the audience for having joined us. You can get more information from the National Catholic Bioethics Center's webpage. I'm sure that Catholic Health has a webpage where you can get information. You can see this event again or circulate it to your friends by going to the Institute for Human Ecology webpage, which is IHE, Institute for Human Ecology.catholic.edu. And the Institute for Human Ecology has many other events there, including, which you can view if you haven't, the first collaborative effort between the Ncbc and Catholic University on palliative care. So we thank you for joining us. We look forward to future collaborations with the Ncbc on other topics like this. And I personally thank both panelists because it helped me to think about things that maybe I'm not thinking about enough. So thanks to everybody. See you again soon.